without any further ado, our presenter today is Joel Gurin from the Center for Open Data Enterprise, or CODE. And in this presentation, Joel's going to provide an overview of the SDH framework from his work with the U.S. Department of Health and Human Services and healthcare industry leaders. He's going to describe how SDH data can be used to improve HIV-related health equity and how an SDH-focused approach can improve the nation's health overall. We're going to have time at the end of this presentation for some questions and answers. So go ahead, keep track of your questions as we move through the presentation, so that we can make sure that we answer all of our questions while we're here together. And without any further ado, I'll turn it over to you, Joel.
Probably helps if I go off mute, right? Okay, very good to see you all. Patrick, thanks for the introduction. I'm Joel. I'll be talking for probably about a half hour and then really look forward to your questions and also to learning from all of you. One kind of thing you should know about me at the beginning: I'm not a healthcare professional. You all, I think, have a lot more, much more on the ground experience than I do in healthcare. But what I am is somebody who's worked on issues around data and the use of data for a long time, including a lot of work with the U.S. Department of Health and Human Services. So what I'm hoping to do is kind of give you a sense of how some of the folks that we work with at HHS and other health experts are seeing the role of data about social determinants of health today. As Patrick said, the concept has certainly been around for a long time. Data has been around for a long time, but I think we're seeing more and more kind of targeted and sophisticated ways to use this data to really address and help individuals and communities that are at high risk of HIV and many other kinds of health issues. So that's what I'm going to be talking about, and we'll really look forward to your questions as after I've gone through all of this. Patrick, if you'd like to do the next slide, right? So just a pretty standard definition of social determinants of health. The SDH are the conditions in the environments where people are born, live, learn, work, play, worship, and age. And as we know, they affect a wide range of health functioning and quality of life outcomes and risks. That's a pretty self-evident statement. I think the question becomes, how do you apply that? How do you understand it? And how do you make it quantitative? How do you find out what kinds of data are really going to help you understand the impact of the SDH and intervene in helpful ways? So to begin, I'm going to, whoops, I don't think we're there yet. Okay, next slide. There we go. Perfect. Thanks. I want to just tell you a little bit about my organization. So Center for Open Data Enterprise, or CODE, is a group that some colleagues and I founded in 2015. We came out of a lot of backgrounds, including experience in journalism, experience with nonprofits, experience in the federal government, and really saw a need. You know, the federal government in particular has huge amounts of data. If you go to the website data.gov, you will see there's more than 335,000 data sets. And I think they're still counting. And the problem is, of course, that there's a lot of barriers to using the data. There's often a lot of poor communication between federal agencies and all of us who they're meant to serve. So what we're really about is making those connections, making connections between the people who provide data and the people who use data. It's all about, as our mission says, maximizing the value of open and shared data for the public good. If you go to our website, which I think you'll see the URL on the next slide, you'll see a lot of our publications, a lot of work we do. We do research and we publish papers. We provide online resources. And one of the, I think, most unusual things we do is we hold roundtables of up to 100 or even almost 200 people, where we really bring people together and have a very focused kind of conversation about how data can help in the real world, how it can really help us all reach the kinds of goals that we want in healthcare or in other areas. And to tell you a little bit about the work we've done on social determinants of health, on the next slide. Yeah, perfect, thanks. So if you go to, you can see the URL, it's opendataenterprise.org publications. If you go to our publications tab, everything we've ever published is up there. And in particular, you'll see the results of some roundtables that we did with Health and Human Services over the past couple of years. We did one initially just on the broad question of how do you use social determinants of health for good. We then, in the middle of the COVID pandemic, did a report on using SDH data, particularly to focus on COVID-19 and recovery efforts. Then that led to a roundtable on what HHS called cross-sectoral collaborations on SDH. Because if you think about it, you think about what are the kinds of things that pertain to the social determinants of health. It's not just data from HHS, it's also data from Department of Transportation, Department of Commerce, Department of Labor, and so on. Thank you, Patrick. So the URL is in chat now. So yeah, so it's really a question of how can all these different kinds of government agencies contribute to improving the kind of data we can all use, and also how can state and local agencies do the same thing. We then did a roundtable with the IBM Center for the Business of Government on particularly the use of data to advance racial equity in healthcare, which is an issue, of course, that is so closely tied to social determinants. And we did a paper with a population management health data management company called Z Omega, that is doing some really interesting work applying social determinants using artificial intelligence in a very sophisticated model to really support improvements in health. And I'll talk about that a little bit in some of the next slides. So the next slide gets us, this slide shows some of the partners we've worked with, including not only HHS and Z Omega, but also the Patient-Centered Outcomes Research Institute that supported a lot of our work. So we always want to thank them as well. So now on the next slide, this shows a framework. I think a lot of you are really familiar with the concept and the way that SDH factors are talked about. This is different people have sort of divided these up in different ways. This particular segmentation comes from Healthy People 2030. From the Department of Health and Human Services. And this is very interesting because, Healthy People is something they've done every 10 years for a long time. When they went from Healthy People 2020 to Healthy People 2030, I think was really a stronger focus on SDH than any that they had ever had in the past. There's 358 kind of objectives for the nation that are spelled out in Healthy People 2030, and a lot of them, you'll see if you go in there, are related to the SDH. So if you just look at what some of these are, healthcare access and quality, of course, is kind of an obvious one, but thinking of that in the context of social determinants, not just how good is healthcare, but what really determines if somebody has access to good healthcare. That's a critical thing. Neighborhood and the built environment includes all kinds of things. It includes housing, not only the quality of housing, but where housing is located. Are there parks nearby? What are the crime and safety factors in a neighborhood, and so forth. Social and community context includes many, many things, ranging from social connectivity to, individual behaviors like smoking, alcohol use, and so on that have a social component. Economic stability, and when you think of this from a data perspective, you think of things like statistics on employment, public assistance, income overall, and education. We know has a very high correlation. More than 1/3 of people on Medicaid, for example, have less than a high school education. So we know that in all kinds of ways, these factors impact health. And I'm going to talk a little bit more later on about how we think some of these are really interrelated, but you have strong influences from all of these segments on health and also access to healthcare. The next slide shows you a little bit about how this concept can be used. And as I said, while what I just showed you is now the kind of classic Healthy People 2030 division, there are many ways that you can look at the connections between variables and subvariables and so on. This is an analysis that our partners at HHS did for one of the roundtables that we held, and through some research of their own. They were very interested in the role of climate change as a kind of social determinant or something that impacts social determinants. They came up with the concept that, or I think many people have now, that climate change is really what you could call a threat multiplier. Basically, everything that can affect health in a bad way, climate change is going to make it worse. And you can see, and this is from one of our publications that you can find on our website, that climate change, even in the short term, has real impacts on healthcare, education, but also and economic security, but also things like housing, transportation, food and water security. So you can use this sort of social determinants framework to look not only at general influences, but really very specifically at how these different factors influence each other, all of which hopefully can be helpful for positive interventions at an individual or community or an even larger scale level. As you think about the context of SDH in care, this also from one of our reports, there really is a kind of hopefully a virtuous circle here, involving clinical treatment of the individual, social intervention, often at a community level, and prevention and risk assessment. So we really see all of these as very interrelated and very much sort of supporting each other. So we're now going to get a little bit more into what are some of these actual factors. And, again, we're really talking about how to use data. You don't want to just say, yeah, social determinants impact health and it's a problem. You want to actually see where those connections are and where an intervention will be helpful. So one of the really interesting things is that while healthcare access and quality is, of course, a huge determinant of health outcomes, there's been calculations have been done, and this I think comes from the Institute for Medicaid Innovation, that healthcare access and quality may actually be one of the lesser factors involved. If you look at the way they break it down, they attribute about 40% of health outcomes to socioeconomic factors, 10% to physical environment, 30% to health behaviors. So again, these other kinds of social determinants having a huge impact. And what's very interesting here is if you look at those top two, socioeconomic and physical environment, those are very linked to zip code. They're very linked to where you live. Things like transportation, housing, income, education, food access, all very location related, while health behaviors are, of course, much more individual. So what that means is that when you're thinking about how to use data to get a better understanding, you really want to look ideally at a combination of things that you can learn about an individual from the clinical setting and things that you can learn about their circumstances really from their address. There is a lot that can be learned now about location-related social determinants that can be extremely valuable. And a lot of what we're seeing in strategies for positive interventions for health really relies on putting together the individual and the more community-focused, location-focused factors. So the next slide gets us now into a little bit about, how do you build out that idea? Well, there are many sources of population level data. And this is some of the kind of work that our organization has done with in working with Z Omega, the population health management company, and with others. Data is available, of course, from HHS, but also from the Census Bureau, Department of Labor, Department of Transportation, Education. That's all on the federal level, as well as many state and local governments. So, this is really, I think, in many ways, an underutilized resource, what we can understand from these kind of public sources of data about different factors, whether it's education, income, transportation, other factors that do vary by where someone lives. There has been a saying now around SDH that your zip code may be as important or even more important than your genetic code in determining health. That may or may not be a bit of an overstatement, but it's certainly a very plausible way of thinking about this. And then on the next slide, you can also see what are some of the kinds of sources that you can use for individual level SDH data. Certainly just what a physician or a physician's assistant or anybody in the healthcare system learns from their patients directly, it can be extremely important. I mean, that's pretty obvious, but we're also seeing the potential for data from clinical trials, health networks, schools, community-based organizations. There is, of course, a huge issue around the appropriate use of this kind of data, huge issues around protecting patient privacy and personal health information. So none of this is to suggest that data should be collected in any way that crosses any of those lines. But within the protections of HIPAA, within the appropriate protections for privacy, within a health network, within a clinical setting, it seems that there's a lot that can be appropriately learned and used to help people get with a better understanding of the social factors that could be impacting their health. So just to give you some examples, these are just some of the examples of the kinds of ways you can look at a social determinant and then look at a data source that's relevant. I mean, we know that access to transportation is a social determinant. We know that a data source there can be Department of Transportation data on how close you are to public transportation, which can have all kinds of impacts on employment opportunities, on education opportunities, which in turn impact health. Exposure to power plant emissions, can be a factor in terms of air quality. That kind of data is available from Department of Energy or from the EPA in many cases. Next slide, just kind of continuing with some examples. Education, early childhood education is a factor. There's data available from Head Start and other programs. Economic stability, access to employment is a factor. Department of Labor statistics are broken down geographically. So when you begin to look at what are some of the sources available, and as I think I said at the beginning, our organization focuses largely on data from federal organizations, but a lot of data is also available on a state and local level as well. There are many, many factors that you can use to sort of begin to understand the communities in which you're working and the individuals in those communities. So then how does this all relate to health equity? Well, all the factors that we've been talking about are factors that are very much related to equity and that are impacted by and impact equity on many levels. This again comes from some of our work with HHS. One of the things that becomes very clear as you look at some of these factors is how incredibly interrelated they are. So this diagram just shows at a very, very high level how particularly 5 of the factors we looked at, economic stability, housing, environmental factors, transportation, and education are all interrelated. And even though for simplicity, we just drew this like it was a circle going in one direction, in fact, there's kind of invisible arrows all over the place. I mean, housing, for example, the location of housing affects access to the high quality public education. Transportation, as I mentioned a minute ago, affects your employment options. So all of these are interconnected. Healthcare is a little bit different because access to healthcare and quality of healthcare are actually sort of impacted by all of the things in the outer circle. And we also found that food security, which is hugely related to health, is impacted by all of the things in the outer circle. So there's just tremendous interrelationships here. And the bullets on the left show you a little bit about how some of those relationships work and also what some of the impacts are. So food security, for example, is not only affected by all these factors, but it also can have impacts on diabetes, hypertension, heart failure, housing instability, among other things, relates to lower adherence to treatment if people are in an unstable situation. Transportation barriers relate to access to healthcare, whether people can get to their appointments, whether they delay care, issues in medical compliance as well. So I think, the main kind of lesson here is that is that all of these factors are quite interrelated. and to really get an understanding. You don't necessarily need to look at every possible interrelationship, but looking at any of these aspects in an individual's life, in a community's life, is likely to yield some insights that hopefully will really lead to some ways to improve people's situations and improve their health. So if you look now at the kinds of health issues that have been studied with regard to SDH and health equity, HIV/AIDS has been a lot of research, which I'll talk about in just a minute. But I'm also going to talk a little bit about diabetes, asthma, and some other factors, because those, I think, can give you kind of a general sense of how all these, how SDH factors in general work to impact health and what can be done. So let's start on the next slide with SDH, HIV, and health equity. I'm going to show you a couple of maps, and these come from California PTC. That really show some of the relationships with poverty, education, insurance coverage, and housing. The first one actually shows the really strong connection of HIV incidence and poverty, and this comes initially from, as all these maps do, from statistics compiled by the CDC. You know, the darker colors show higher HIV incidence. The darker colors show the number of households below the federal poverty level. I mean, you don't need to run a complex analysis to just see how these things track and the degree of correlation in these different states. The next slide shows a very similar pattern around education. And the slide after that shows a similar pattern around health insurance. So all these factors, which of course are very interrelated themselves, education, income, insurance, all are interrelated and all really correlate with the incidence of HIV. The next one, I think, is a little, here the correlation is not quite as one-to-one. And this one, I think, is maybe a little bit more complex. Here we're looking at the relationship of HIV incidence to vacant housing, which is, you know, a measure of housing instability. And again, I think here we're seeing, and I know housing is going to be a whole topic of one of these webinars because it's such a huge issue. But there's so many issues in which housing affects how well people can access healthcare. It relates to economic stability. It relates to food insecurity, which in turn relates to you know, susceptibility to HIV physically. So we're seeing, you know, many different kinds of issues here. If you go to the next slide, you know, I'm just going to show one or two slides that show how some of these same patterns also relate to the risks of other kinds of illness as well. And this comes from some of the work that Z Omega has been doing to understand. Z Omega is a company that serves healthcare organizations as payers as well as providers, and they've really been working with them to try to identify what are some of the SDH factors that might alert people to individuals who might be at high risk and might also help lead to interventions around connections to better social services and care and so on. So the diabetes numbers that we're just looking at are actually all for type 2 diabetes. One of the things that what you're seeing here basically is that the leftmost bar is people below the poverty line. The rightmost is people who are at least 4 times that poverty level income. And you can just see how low income is clearly related. This is all type 2 diabetes. What through factors presumably that include diet, exercise, and so on. One of the things that's not shown here is that it's not only the prevalence of diabetes, but hospitalization rates for diabetes are about 30% higher in high-risk areas, low-income areas. So you're seeing real correlation here with that chronic disease. And then the next slide really looks at a very similar correlation between income and asthma, um, not only because of environmental justice issues and the fact that people in lower income areas are likely to be living closer to industrial plants and may have poor air quality and other kinds of environmental factors, but also that the kinds of things that can be done to improve indoor air quality, like buying air filters, getting rid of old carpeting, doing mold remediation. These may all be, more difficult for people who are at a low income level. So again, we're seeing, many ways in which factors affect many kinds of outcomes. And then the next slide really just looks at the impact of education, and without going into detail on all the nuances of these charts and graphs. Essentially, this is a way of looking at how both income and education level impact smoking and exercise habits. So again, seeing the relationship here with individual health behaviors. So, the question really becomes, what do you do about this? What can, all of you as health practitioners do to improve the situation? And this again comes from Ziomega's work. The model that they're working on, and they're actually doing a fairly sophisticated data model involving AI analysis and so forth, but it really all comes down to clinical care. What they're working on is bringing together data on the individual with data on where they live. So, data on the individual can be gotten from surveys, again, protected by HIPAA, can be gotten from interviews with physicians, nurse practitioners, other healthcare professionals. But what they're finding is that you really get a much deeper view if you look at not only individual factors, but also all the SDH factors that are related simply to location. And, if you look at factors including income, education, but also access to transportation, housing, environmental factors, air quality, you're just going to get a much more extensive picture. And a great amount of that data is already available publicly, so it can be accessed and it can be used. And this is just a sort of hypothetical where they take two women and they say, let's say you had two women who have exactly almost identical jobs, same income themselves, same BMI, but they have different locations. And one thing to note here is actually that that to really get a precise view, and this gets a little bit into the complexities of data and available public data, but zip code is helpful. Actually going to a more local level and looking at census tract data is much more helpful. Not all federal agencies collect data at that level. The CDC does, the Census Bureau does, many others do not. But again, whether you're talking about data sources or simply talking about a kind of principle of really understanding where someone lives and the impacts on them of location, more precise location is going to tell you more that can be helpful. So anyway, in Ziomega's hypothetical example, these two women might start out in the same place in terms of their health, and they're starting out with almost identical kind of individual risk factors. But if you go to the next slide, you can see that over 10 years, they really could have very different health courses in ways that could relate to SDH factors related to where they live. So what do we do about all this? Well, I think there's a lot that clinicians and healthcare providers can do simply by being aware of these factors, by being aware of the range of factors. It's not intuitively obvious that access to public transportation could impact health, but it does. It may be more obvious that housing can impact health, but the ways in which that happens are complex. And as I said, you'll be learning about that in one of the other webinars. So I think part of it is really awareness. Part of it is figuring out what kinds of data it's possible to get about an individual situation, about their community, what's ethical to do, what respects privacy, what respects community rights, and yet can still be helpful. And we put together in our work a number of recommendations that are a bit more sort of at the policy level, but just kind of to show you what some of that thinking has been. And you can see it on this slide. I think there's a lot of ways that could be a lot of things that could be done to better support community, local, and state-based decision makers. Certainly, community-based organizations of all kinds are central to this work. Hyper-local snapshots, again, the more you can learn about a real precise locality, the more valuable that will be. The Healthy People 2030 framework I mentioned before is very much worth taking a look at, particularly because of the strong focus there on SDH. Using sometimes the CDC has a tool called the Social Vulnerability Index. It's not perfect by any means, but it can be a way of looking at factors related to health risk in different parts of the country. And the next slide, our recommendations talked a lot about things that really are at a government level around standardizing SDH data better, creating a better infrastructure for SDH data. But if you look at these last couple of bullets, I think they're really more widely applicable as well, and applicable to healthcare providers. You know, the more you can get SDH data that will be helpful, things that you can not collect from patients in a kind of extractive way, but that you can use to have a conversation with somebody that you're treating. In many ways, the most important use of data is the human factor. That knowing something about somebody's life, knowing something about the SDH aspects of their life, could open a conversation about not only their blood pressure but their job. Not only their exercise, but their access to parks, or use of transportation in ways that are going to support their lives and so on. And in many cases, healthcare providers have an opportunity to identify needs and help people find the services that are going to really help them with all of these factors. The ultimate message is that SDH factors are intimately related to health, that these factors operate on an individual and a community and even a larger scale, citywide or statewide level in some cases. And that these are factors that healthcare providers have an opportunity to discuss with the patients, with community leaders, and really work together to find solutions that are going to improve both quality of life and quality of health. So that's how our work has focused in this area. Any of you, I'm always happy to have emails from folks who want to talk about some of these issues. I would urge you to go to our website, odenterprise.org. As I said, if you look at the publications tab there, you will see everything we've ever done on this subject. We've got actually a whole section on work that we've done with Health and Human Services. And if you look also at a section called Independent Roundtables, you'll see some of the work that we've done with others that have involved HHS but have not been partnering with HHS. And also, if you go to the impact page of our website, you'll see the impact that we hope our work has had in a lot of this thinking about healthcare and other topics. We are all about the use of data for social good. And I hope this has given you a bit of a sense of how we approach that with health and healthcare and the SDH. So let me stop there and would love to take any questions.
Excellent. Thank you so much, Joel, for that very thorough overview of how SDH are impacting the health and wellness of our communities, and particularly with HIV. Let's use your reaction buttons, if you all can. You know where your reaction buttons are, and give Joel some love. Let's see a reaction. All right, you got some love from Terry, some love from Frank.
Thank you all.
Christy's ready to party. Yeah, thank you very much for that. So we have some time here for any questions, and you can either put them in chat or bring yourself on camera. Don't be shy. We're in a
And I
safe
would say
environment.
not
Yeah.
just questions, but your own observations, your own comments. As I said at the very beginning, I am not a healthcare practitioner. Would love to hear what some of your observations and experiences have been too.
So we'll open it up, and we're in just a minute. We're going to break into 3 different rooms. We've got some questions that we want to more thoroughly explore. So, but before we do that, any comments, any questions, any stories? Yes, Francisco, please.
Yeah, so talking about social determinants of health, and when you were using the 2 examples of the workers that were identical, I just want to ask, how does ethnicity play a role in any of this?
Yeah, so that's a terrific question. We've done one of the one of the publications that you'll see on our website is a project we did not do with HHS, although they participated, on the use of data to improving equity in healthcare. And I mean, you know, we are not experts in that area. We try to do some work in that area. There are other people who are, I think, smarter about it than we are, to be honest. But there's so many factors. I mean, you're clearly, you know, there are going to be some correlations with some social determinants and race and ethnicity, but you're also, of course, looking at racism in the medical system. You're looking at the impact of bias with the increasing use of AI. There's a lot of concern that some of the algorithms may be biased as well and lead to the extent that they support clinical decision making, those may not be so great. So I think, you know, the way that's, as far as I could tell, it seems that the way that social determinants have been studied, that there's a whole set of analysis around factors like income, education, some of the other factors we talked about, looking at them independent of race and ethnicity, but that if you really want to understand how the healthcare system is or is not serving people, you have to also look at all the issues of bias and other issues directly related to race and ethnicity that come in. Does that make sense? Or, you know, does that, yeah.
And I'd like to add, also, there are a number of different studies that looked at, I'll use food security as an example. In our social determinants of health online course and in our live course that we would do, we showed a video called The Tale of Two Zip Codes. And it's basically what Joel just described. And it's looking at just one zip code over. And I can tell you, when I was studying social determinants in the beginning, I was living in Long Beach, California. And I decided to do some research on my own. And one zip code over from me, the average life expectancy was 14 years less. One zip code over from me. This hasn't been published, this was just my own research. And as I looked at the makeup, I was really curious to see what were the differences between my neighborhood and one zip code over. And you know, the people who lived in that zip code over largely were people of color. And again, for all of these reasons, the racism, the access to education, the employment opportunities, and food insecurity, all were factors in that, in all of these higher rates of disease. So it's really interesting.
Well, and if you look at particularly like environmental justice issues, which we've been involved in to some degree, I mean, there's a lot of analysis showing that you know, the siting of industrial plants that pollute the air is really related to, you know, to racism. You know, that it's environmental racism. It's not only related to these other factors. So, you know, there's a lot of, if you look at one of the unfortunately most predictive things you can look at geographically to predict a lot of different kinds of you know, economic opportunity issues is the old redlining maps, which were, you know, entirely based on race. So, I think there's a lot of sense that the social determinants that just look at these kind of quantifiable factors like the ones we've been talking about are an important part of the picture, but that the dimension of systemic racism and the impact that has on health is another thing in and of itself, and that they're both really critically important to address.
Yeah, yeah, and I think another example of this would be what we saw a few years back in Michigan, right? In the Detroit area. And by the way, when you look at the makeup of Detroit and with regard to food security, I think it was crazy the unavailability of grocery stores in certain areas in the inner city of Detroit compared to the suburbs. People didn't have access to fresh fruits, vegetables. There were a lot more convenience stores and fast food restaurants and things like that. So it all plays a role in the health and wellness of our communities.
So,
Oh,
Francisco, thank you. I mean, obviously, a big question, and thanks for asking. And I think we're all trying to figure this out together. Other questions or comments? Yeah.
well, please, if you think of a question or you don't want to ask it here or put it in chat, we'll be sure to either answer the question before the end of our time together today. If we can't do that, we'll be sure to get you the answer, shortly thereafter to the best of our ability, or put you in touch with somebody who can give you the answer. Thank you, Joel. We are going to now break into three groups, three breakout groups, just so we can have a little more intimate discussion. We've got a few questions that we want to ask of you. Whoops, there we go. And so in just a minute, Glenn is going to be breaking us in. We're going to be asking these questions in our breakout groups. So one group will be facilitated by Azul, one group will be facilitated by Greg, and one group will be facilitated by me. And we're just going to explore some of these concepts a little more deeply. So we're going to have 15 minutes to do that, and then we'll come back here and we'll wrap up. So whenever you're ready, let's go to our breakout room.
And I will say goodbye, but please feel free to contact me and would love to hear your thoughts. And thanks very much for your time.
Thank you so much, Joel, and we'll be in touch. Thank you.
Bye-bye. Bye.
All right, so go ahead and press your join button, and we'll see you in the breakout room.
Welcome back, everyone. Welcome back.
All right.
Everyone's coming back. There we go.
Let me share my screen. Thank you, everybody. So we had some really good discussion in our group. I'd love to hear from others. Anybody, what did you discuss? How were those discussions? Let me,
Well, I'll go first since I was group number one.
thank you.
There was a lot of discussion about action, data to action, and how do you make it, how do you make what you have or what you can gather from different resources actionable? And the other kind of topic we focused on a lot was how to break down and really hone into specific communities or segments of the community that you want to engage with because they're the most, highly impacted. Like Patrick's example of the next zip code over. It could be a zip code basis, it could be even more, census basis, et cetera. And then just looking at how all the different things combine and how, to think of the things that we might not necessarily think are associated with health and how those influence health outcomes. There was some discussion about the HIPAA challenge and how to kind of bridge the gap between what the health department has and what community-based organizations need, et cetera. And more personnel, more resources was a big issue. We talked about how, in communities, resources and access are an issue. That is also true in health jurisdictions, that if there's not enough, staff, that you can't necessarily do things well. Unhoused, the importance of, making connections with people who are boots on the ground and working in communities that we want to reach and get to gather information from that are not necessarily, accessing services elsewhere where that information could be gathered from. Networking, cross-jurisdictional networking, looking at how other people are addressing different things and how maybe what you're doing in your jurisdiction might help somebody else. And then the last thing we talked about was really about using social media and understanding the habits of the community based on social media and how to kind of use that information effectively. It's maybe not traditional public health data, but it's information about a community that could be useful.
Absolutely. Wow. You all talked about a lot in a really short period of time. I'm impressed. Thank you for that. Azul.
We really talked about, the significant changes between zip codes and how to utilize that data to inform how you provide services and where you provide services. And then the other topic that we touched upon is getting to know resources around you and other agencies so that there's not duplication of services, and understanding if there are a lack of services within zip codes where the data is pointing you.
Excellent. So again, putting that data to work, we're not just collecting all of this information to have it sit on the shelf somewhere or end up in a publication, and that's where it ends. We need to actually utilize the data that we're collecting. We talked about some funding issues, and this certainly came up in a meeting I shared with the group that I was at last week. But the funding restrictions that sometimes we face, and what can we do based on who's funding us? How can we address some of the, this is just an example, but if you've got a substance use issue, well, then SAMHSA is going to fund that program. And if you've got a disease thing, CDC is going to fund it. But we're talking about the same people often, right? And don't even think about mental health, right? Which is, it's always been historically poorly funded in this country compared to the need. And so, how can we break through some of these funding silos and funding restrictions so that we can more thoroughly do what we need to do? And then the other thing that we talked about was the importance of including these, what they call these non-traditional partners. And I thought that Joel did a really nice job of showing us that you can get really important, not only important data, but buy-in by partnering with the Department of Transportation, for example. And I've been on planning groups throughout my career. And when was the last time I saw somebody from the Department of Transportation in an HIV planning group? I'm not sure that I ever have. I know that we've had Department of Education there from time to time. I don't recall ever having the Department of Labor at our planning groups. And so when we think about, how do we more thoroughly address these issues? Well, we have to get the engagement and buy-in from representatives of these various communities and these various sectors of the communities. So be thinking about that next time you're wondering, who's not at the table. Look at the social determinants of health and look at these data sources. You will see the overlap, and then let's invite somebody from the Department of Transportation to our table, because it's obviously a big issue in health in general, but also specifically to HIV. Others, any questions or comments? Well, not being one to belabor things, that's not very true. Sometimes I can belabor the hell out of something. I really can't. But anyway, we don't want to do that to you here. Let's ask the other poll question. So now let's, in just a minute, Glenn's going to put the question up. I can explain 3 ways that SDH data can be used to improve HIV-related health equity. And so,
Hold on, Patrick, having a little technical challenge here. Hold on.
Ruh-roh.
Not launching on it. Greg, can you see if you can jump in poll 2 question?
And if not, we'll give Greg a chance. But if for some reason it doesn't work, go ahead and put it in chat if you wouldn't mind.
Yeah.
Oh, there we are. Well, that's poll question 1.
Yeah, hold on. Just trying to get there.
Oh, there we are. Yeah.
There you go.
Yay,
Sorry,
thank you,
took me a
Greg.
minute.
There we go. Teamwork.
Greg's a magic man. All right. Okay. So come on. We want, where are we? Keep them coming. We got to get that 80% threshold. 80% threshold. Come on, come on. 3 more seconds. Don't be shy. Press that button. All right. Well,
Okay, I'm gonna go ahead and end.
yeah, let's stop there. Thank you. So it looks like there's been some movement And so good. We're glad to see that. I know that I certainly learned something from Joel's presentation, and it really made me think about some things that maybe I kind of already knew, but it gave me some ideas of maybe some new ways to approach things, and the importance of really, let's face it, data is crucial to our efforts because we need to be reporting, to our funders, and without data, you have nothing. And so we need to collect that data, and we need to share it, and we need to share it back with the community. So, however you need to do that, town forums, town halls, putting, articles or whatever you do. But so often we collect all this data and it doesn't get back to the communities that we're serving. And, I don't know about you, any of you who've ever done data collection, I'm always amazed at what people are willing to share with us, even on the street, asking these interview questions, and people will just tell you all kinds of stuff, but how often do they ever see the fruits of their labor? How often do they ever hear the outcomes of all this data that we collect? So it's a really important part of community engagement to be sharing that back with the communities that we're collecting it from. So don't forget about that piece. And before we end, are there any final questions, any comments about the session? Again, I want to thank you, Joel Guerin and Matthew Rumsey from Code for putting together that presentation, sharing your time and expertise so that we can all work together to end this HIV epidemic by 2030. I'm not kicking it until it's done. So, and I'm getting older up in here. So we got till 2030 to meet that goal. And I think we're going to do it. I'm very, very excited about this. I hope that you are as well. Listen, it's not over. So coming up on Thursday, come back for session 2. We're going to have Amy Griffin from HRSA here, as well as Christina Santana from NASDAD. And they are going to be talking about the impact of unstable housing as a social determinant of health, and how unstable housing, we're really going to get into it, how it's leading to negative health outcomes and HIV transmission and acquisition, as well as negative health outcomes in general for people living with HIV. And yeah, that's all I want to say for today. Greg, did you have anything you want to share?
Yeah, I just put in the chat, I